Thank you very much for joining us once more on Oncology Beyond the Obvious. We are definitely taking a closer look, and we are honored to have Professor Hope Rugo today as the interviewee. uh, for an audience of oncologists from India and the South Asian region, Professor Hope Rugo needs no introduction. But definitely, I must say a few things because we have to remind the youngsters who may not have heard her earlier. So, Professor Hope Rugo is Professor of Medicine and the Wintroff Family Professor of Breast Cancer. In addition, she is Director of Breast Cancer and Clinical Trials Education, as well as Medical Director, Cancer Infusion Services at the UCSF Helen Diller Family Comprehensive Cancer Center in San Francisco. We all know the enormous amount of cutting edge and landmark trials published by her, especially in breast cancer. And it's not surprising that she is co chairing two very important committees as far as breast cancer is concerned. One is on the phase 3 I-SPY 2 trial, and the other is the triple negative working group of the Translational Breast Cancer Research Consortium. Welcome, Professor Hope Rugo. And
Thank
today,
you so much.
uh, and today we'll ask uh, Professor Amish Vora to begin interviewing you. And the title is MonarchE trial sufficiently flawed to question its data regarding adjuvant abemaciclib in breast cancer? Over to you, Amish.
Thank you, sir. Can I share my slides?
Sure, sir.
Yeah. So are my slides visible?
They are.
Perfect. Thank you. And before we start the interview, as our customary thing, we will present a little bit about the paper, what we are going to discuss today. And Sudeep, thank you for this idea. I think OBTO owes you a lot. Today, we are going to discuss MonarchE, adjuvant abemaciclib in high-risk early breast cancer. Before we say that, I just wanted to highlight to everyone, those who don't know, Dr. Purvish Parikh, teacher, and myself, student. We together started this OBTO called Oncology Beyond the Obvious. One of the most important thing about Dr. Parikh, I would say, is that he always encourages students to come forward. And in this OBT also, he has been the backbone and he always tries to give me limelight. And I enjoy that. And that's why I've written a student, because he has got many students like me. Thank you so much. And with that, come back to MonarchE was published twice, once in 2020 and once in 2023. It was the early interim analysis. And now also, if we see, it's a 42 months of follow-up, which has been published in the Lancet this year. And as we know, Dr. Hope Rugo, as I have highlighted, is one of the author, and we are very fortunate that she is with us today. Very high risk early breast cancer were taken in this. So there was cohort 1 and cohort 2. Cohort 1 included patients who either have more than 4 positive axillary lymph nodes, or if they have 1 to 3 positive lymph nodes, they should have at least one of the three below: tumor size more than 5 centimeter, grade 3, and Ki67 more than or equal to 20%. After 1 year, the cohort 2 was started, where they took patients of node positive and Ki67 more than 20%. Patients were randomized into 1:1 fashion amongst 5,637 patients. This is a large number of abemaciclib 150 mg BD for 2 years with standard of care endocrine therapy. It can be tamoxifen or AI, either of that, 5 to 10 years as clinically indicated. And the control arm was only endocrine therapy as per physician's choice. Primary objective is invasive disease-free survival. From here, I will call it as IDFS as per the STEEP criteria. And overall survival was the secondary endpoint. The first paper in 2020, there were more than 2,000 patients who were on treatment as yet, and there was still what they saw was, I will just present, and in Lancet of January 2023, what was seen is that majority of the patient, in fact, all the patients had completed 2 years of abemaciclib. None of the patient was on the treatment. So we can call it as a mature data, which is there. In terms of the patient characteristics, I wanted to highlight that there was almost an equal distribution of pre and postmenopausal female. 15% of patients were more than 65, and there was a subset analysis which was presented recently, and that's why I highlighted this. This was little surprising, and maybe either me or Dr. Tarini will cover this point. Was although there were 70% patients belong to stage 3, the uptake of neoadjuvant chemotherapy was only in 37% of patients, but majority of the patients, though didn't receive NACT, received ACT. This was again one of the highlight of the paper, that Ki67 more than 20% was present in 43 to 44% of patients in both the groups. Again, I wanted to highlight that in the premenopausal female, tamoxifen was given in 30 to 32% of patients with abemaciclib. And why I'm highlighting this, we would highlight it when we discuss of side effects. This was primary endpoint IDFS at 2 years with a hazard ratio of 0.75, and at 4 years IDFS was with the hazard ratio of 0.664. It was statistically significant with an absolute benefit of 6.4%. This OS data, according to authors, is not mature, and I have tried to understand from Sudeep about that, and I'm sure we will try to understand from Dr. Rugo also more, because I cannot see the difference between the blue and red line even after 42 months of follow-up. Side effects, I would like to highlight in the black box what I have put. 46.2% of patients in abemaciclib had grade 3 side effects, as compared to 15.7% of patients in endocrine therapy alone. US FDA approval has been revised second time. First, it was approved only in patients of Ki67 more than 20%. But in March of 3rd, 2023, FDA has removed that one caveat, and it has broadened the label in all these high-risk patients. There were 2 subset analyses which were presented recently. Age, irrespective of age, the benefit was seen. And neoadjuvant chemotherapy, the curve separates at 2 years itself. So that means it was a high-risk group, and abemaciclib is supposed to work slightly better in this group. With that, I would stop sharing my screen. And with this background, let us start our discussion. Dr. Rugo, if you are ready.
Yes.
Okay, perfect. So Parikh sir introduced Dr. Rugo, but one very interesting feature which I found about Dr. Rugo, I saw many of her videos which are obviously very, very famous. And she uses one word, interesting, very much. She would use this as interesting paper, interesting data. This was an interesting study. And I was very, very intently looking at that, about that word. So with that, Dr. Rugo, let's start. First 3 questions, Dr. Rugo, are rapid fire questions. And I would humbly request you to give only yes and or no, and then we will elaborate on that going forward. First question is, according to you, is IDFS an acceptable primary endpoint for US FDA approval for abemaciclib in high-risk HR positive, HER2 negative early breast cancer?
Yes.
Perfect. In MonarchE, do you think as data matures, we will see OS benefit?
Yes.
Okay. Have you started practicing MonarchE in your clinic?
Yes.
Oh, excellent. So we have the 3 commitments from you, Dr. Rugo, and let's go forward. The next question is about the question 1 about the IDFS. When I look at the IDFS curve and OS curve of MonarchE, it reminds me of affinity trial curves. The pertuzumab, addition of pertuzumab, and then the subset analysis of node positive and that. I want you to elaborate why IDFS, especially in HR positive patients, where the survival post progression is going to be for many years, should be accepted as the acceptable primary endpoint for us to change our practice.
I think that there are several points that play a role here. First of all, you need a large number of patients in order to see differences, and you also need to select a high-risk group of patients or patients with a high risk of relapse where you have at least a portion of patients who have a higher risk of relapse in the first 5 years. We know that the natural history of hormone receptor positive disease is that we see about half of the recurrences in the first 5 years and about half of the recurrences from year 5 to 20 plus. One of the things that's, I think, changed, and we've seen that from the early breast cancer trials group, but it lags behind, is that as we've intensified our early endocrine therapy for patients, we can actually select out a group of patients who have a higher risk of earlier recurrence. Although IDFS includes local recurrence, local regional events, the majority of events are not local regional in this group of patients, which is interesting. If you selected a group of patients who had, low grade stage 1 T1C cancers, you wouldn't see this difference. But in patients who have more disease burden or more proliferative disease, we do see this early risk of recurrence, and that's been seen in other studies, and that led to the selection of a higher risk group of patients in MonarchE. And the rationale for that is exactly what you were talking about. You want to see that the distant relapse-free survival mirrors the IDFS. So why would IDFS be an appropriate endpoint? Only because you've selected a group of patients where distant relapse-free survival mirrors IDFS. We know that distant recurrence is incurable in patients with breast cancer, except for a tiny number of patients with HER2-positive disease. So that makes the affinity curves different from these, in that in affinity, we can expect that a small percentage of patients may be long-term survivors. In hormone receptor positive disease, the median survival, even with adjuvant use of CDK4/6 inhibitors, is and then you develop metastatic disease, the median survival is still likely to be just over 5 years. We saw with the introduction of ribociclib to first-line treatment of metastatic disease that for the first time, the median survival was just over 5 years, so about 60 plus months. But that means that still everybody's dying of metastatic disease. If you can reduce distant relapse, events, that's where you're really going to impact outcome. And if you look at the early breast cancer trialist group, this data predates the use of MRI, the use of radiation therapy that is safer and reduces local recurrence, and in all patients, the standard use of adjuvant endocrine therapy, which also has reduced the risk of distant recurrence for all but the most extensive cancers to 5% or less. So IDFS doesn't reflect a lot of local curative events now. It really reflects distant events. And if patients live for a while with metastatic disease, that's great. We've made advances. But our job is not to increase the survival of patients with metastatic disease first. Our first job is to reduce the distant recurrence events. So that's why I think IDFS is an appropriate endpoint, since distant recurrence in the end will reflect survival. But thankfully, we have more treatments, more chemotherapy for patients with metastatic disease. So survival events will take a much longer time to see.
That's a great point, Dr. Rugo. Just one small addition to what you have said. In the Lancet paper, the second or the third line says that it is an assumption that these high-risk patients, 40% of them will relapse in first 5 years. If you see the introduction of this thing. But here, at the end of 42 months, the control arm, we still have 79% of patients, let's put it 80% of patients who have still not relapsed. Is control arm also doing well in this particular patient? And that gives that I come to my second question based on that control arm, that overall survival, according to paper, was supposed to mature in 2024, 2 years after the IDFS maturity. When do you think it will mature? Do we have enough events right now in OS for it to mature in 2024?
You know, the improvement of treatment options in the metastatic setting for at least a portion of patients in the trial means that it's going to take longer to get overall survival events, which is a great thing for our patients. But it doesn't mean that we want to have more patients with metastatic disease. I think we would all agree that that's not a good endpoint for our patients. If we're treating them in the early stage setting, saying, well, you know, you're still alive, even though you have metastatic disease. The life with metastatic disease for a patient is not the same as life without recurrence of cancer. They're on treatment for the rest of their lives, and mortality is certain from the disease. So indeed, you could say that, okay, in the most recent data set at 48 months, in terms of distant recurrence-free survival, 82.5% of patients were free from distant recurrence who were receiving placebo, and 88.4% who didn't receive placebo, who just received endocrine therapy, and 88.4% of those who received abemaciclib. That means that there's a much larger number of patients at 4 years who don't have distant recurrence. However, if you look at the survival data from the various treatments that we have for the patients who didn't receive a CDK4/6 inhibitor, we could expect their median survival to be 5 years or longer. These are patients with earlier recurrence, so maybe their survival is a little shorter than the median seen in, for example, the Mona Lisa first-line trials. But we've seen that, you know, patients who recur while on their adjuvant endocrine therapy have a relatively shorter overall survival than those patients who relapse later. But still, their survival is, you know, in the 4 to 5 year range. So we wouldn't expect in a trial where the difference between the control arm and the experimental arm continues to increase over time. So it's markedly increased at 2 years compared to 4 years, which means during the time when all patients were off therapy, we're seeing an increase in the number of patients who are free from distant recurrence. Then we know that the overall survival events are going to be pushed out a number of years. We also now have antibody drug conjugates, which have increased overall survival. And we're better able to manage toxicity now than ever before with a number of agents that improve tolerability of therapy. With an understanding of toxicity, we can reduce the drug discontinuation due to toxicity in at least a majority of patients. So I expect that it will take some time. Now, 2024, I'm guessing it's probably going to be potentially at least 2 more years before we see that significant survival benefit, but it may be a little bit longer. One thing that we can't control, which is an unfortunate aspect of clinical trials, is the access to therapy after trials. So if you're treating patients in the metastatic setting, you can have an optional crossover, although it could impact your the survival benefit that you see. We didn't see that, for example, in the Mona Lisa trials. We haven't seen that in the MonarchE trials yet, where we see these big differences in survival, even though a number of patients cross over. But if you're talking about having access to therapy in the metastatic setting, it's quite difficult because you can't mandate the therapy that patients receive who are on your trial once they receive metastatic disease. I would say that saying that you can improve survival in the metastatic setting by using a CDK4/6 inhibitor means that you should delay therapy that's potentially curative, for me, is an empty argument because it has such a huge impact on the long-term outcome of our patients and the quality of their life. And when you see this increase in benefit that occurs over time, I think that for me was the most convincing data that we really are seeing a difference here that is clinically important for our patients and should be incorporated into clinical practice.
Excellent. I think I tend to agree with you on that point. Just a quick, again, sorry, yes or no, because there's a question in the Dropbox. Assuming at the end of 2 to 3 years, if the OS does not show improvement, does anything change as far as MonarchE is concerned in clinical practice?
If you saw, for example, that at 10 years, that there was absolutely no difference in survival, because the curves start to come together. I mean, there's no way, I can't, as a clinical oncologist, I can't really see how, if you have less distant events and that persists and the curves continue to widen over time, that you would have identical survival, because we know that your survival is shorter if you have metastatic disease than if you don't. So it doesn't actually make any rational sense. So you'd have to figure out whether or not the treatment with abemaciclib in the control arm somehow increased your risks of other events. And we haven't seen that. We've done a careful safety analysis, which we published early, and then subsequent safety analyses have failed to show a difference in adverse events after patients discontinued study therapy. So for example, the toxicity from endocrine therapy is similar. In the metastatic setting, we haven't seen any increase in toxicity with CDK4/6 inhibitors over time. For example, the toxicity that you get early is the toxicity you have forever. And when you stop the drug, that toxicity resolves. We don't see, for example, like we do with chemotherapy, a long-term effect on bone marrow tolerance. You don't impact bone marrow reserve. You don't cause permanent neuropathy. You don't cause permanent hair loss or other, cardiac dysfunction, for example. So I don't see any other toxicity or impact that would affect long-term survival. So I think that we need to have the right number of events to evaluate this, but I can't see how, if we really have the patients and the long-term events, that we're going to fail to see a survival benefit over time. It's a complicated type of analysis. You have more than 5,000 patients enrolled over the world, and the median age of the patients guarantees the fact that the longer patients live, other events will take place, which will potentially impact the, affect both arms equally, but we will see the events over time because other survival events will occur.
I think we got our answer. The next question is that, again, this is something you already have answered, but I will still ask that question because this is the big question in country like India. And after Sonia trial, I think this question has become a very, very valid. Assuming IDFS is an acceptable, valid endpoint, Dr. Rugo, say 79% of the patients in control arm at 44 months is without any relapse. Remaining are 21%. If these 21% at high risk and 6.4% absolute out of that 21%, benefit is also accepted, do you think that it is clinically meaningful to subject extra 79% of patients to 2 years of abemaciclib rather than doing something like, PFS1 and PFS2, although I know it is from adjuvant to metastatic setting, but we can look at something like that. What would be your thought, Dr. Rugo?
I would argue that you can't look at something like that in this situation. Having metastatic disease is completely different from having early stage disease. One, you have the chance of long-term survival. We all have patients we've taken care of, the majority, as you point out, who are long-term survivors from breast cancer. They go on to live their lives without the toxicity of therapy, without the known shortening of their survival. How many patients is worth the fact that you're reducing the number of patients who have fatal disease, who need treatment until the end of their life, where their end of their life is very close in sight? If you have an absolute difference at 4 years of distant recurrence-free survival of 6%, how many patients is worth that benefit? And I think that that's always been a question that's plagued us. But even in a country like India, where breast cancer increased in the younger patients, but we still see an increase in hormone receptor positive disease. At what age is a 6% benefit not worth it for you? We know we give chemotherapy for a 2 to 3% benefit. Chemotherapy has the potential for long-term toxicities that will last the life of the patient. And it's also expensive. We give growth factors to support the patient bone marrow status. And then we give antiemetics, and people can't work during the chemotherapy. There's a big issue. With treatment with an oral medication for 2 years, I would argue that in a place where we're happy to continue endocrine therapy in patients with high-risk disease for 10 years, the 2 years of abemaciclib, which completely resolves, where the side effects completely resolved after 2 years, is much easier for patients than taking 10 years of endocrine therapy. And it's also in some ways easier than the intense and potentially long-term toxicities of chemotherapy for patients where the benefit is quite modest. So, I think we figured out that you needed about 15 patients to have one reduction in distant recurrence based on the MonarchE data. Using PFS2, or the idea that your progression-free survival in the metastatic setting could add to your distant recurrence-free survival, I don't think any patient would agree with. And, when we did surveys saying how much treatment was worth it for patients, they felt that a 2% reduction in recurrence, and this was all recurrences in, disease-free or relapse-free survival, was worth taking chemotherapy. Even 4 cycles of docetaxel cyclophosphamide, where we do have the risk of long-term toxicity. The other thing that I think is really important when you're thinking about that 2 years of abemaciclib is it's not just that you take the 2 years and you have the benefit then. The issue is that, and I think, again, as I mentioned, what was most convincing to me is the increasing difference over time. And on top of that, we have validating data with the NATALEE trial, where we've seen with only 20% of patients completing 3 years of therapy, that there already is a significant, although much smaller, difference in IDFS and DRFS. So if we continue to see that difference widening over time as well, I think that's the first time where we've seen a non-endocrine agent have this carryover effect where we're continuing to reduce recurrence long after completing therapy. I mean, twice as long as we gave the treatment, we're seeing an increasing benefit from taking the drug, which I think is quite convincing.
Great, Dr. Rugo. We have just 10 more minutes for this interview, and I have 3 more questions to cover. So my next question is, let's look at the design of the study. Cohort 2, high Ki67, the enrollment started 1 year after cohort 1. That is what the paper says. Wanted to ask you, any biologic rationale which is associated with high Ki67, which directly affects the CDK4/6, and if you inhibit the CDK4/6 pathway, it will work better? And why I'm asking this question, because the initial FDA approval was high Ki67. But if you see the Lancet paper, the line itself says, it is written that in cohort 1, effect of abemaciclib in IDFS was consistent whether high or low Ki67. So in 2 years' time, the high Ki67 became irrelevant, and there was a cohort 2, which was probably an afterthought. Would like to know, because you're one of the authors, what was the thought process behind the entire Ki67?
So the thought process behind both the high Ki67 and a little bit of the initial FDA approval was that Ki67 had long been suggested to be a prognostic factor for early stage hormone receptor positive breast cancer. But we didn't really have very clean data, and there was a lot of issues about whether or not each center could accurately evaluate Ki67, so much so that we have an international Ki67 working group to tell us how to do this test and what antibodies to use in order to assess Ki67. What this trial showed definitively is that Ki67 is prognostic. So the idea here was to say, okay, we believe that the CDK4/6 inhibitor will work in patients who have a higher risk of early recurrence. So we're going to do that based on standard disease characteristics, amount of cancer that patients have and grade. But what role does Ki67 play? So I think in a very clever approach, we were able to include a small group, 9% of the total trial population, who had centrally confirmed Ki67 at 20% or greater based on data from previous trials. And the study shows, looking at Ki67 overall in the cohort 1, that Ki67 was prognostic, but not predictive of abemaciclib benefit. And the prognostic significance of Ki67 is quite high, which I think, so much so that in the control arm, in cohort 1, Ki67 high at 36 months, the IDFS was 87.7%, but in the Ki67 high, it was 80.3%. That's more than a 7% difference in invasive disease-free survival events, and that difference continues to widen over time. So in other words, at 48 months, it's 75 versus 84%. I mean, these are big differences, almost an 8% difference at 48 months. So what that does is this data really helps us as clinicians create a prognosis that's real for our patients. Ki67 plays a role in prognosis, but it doesn't help us decide about the benefit of abemaciclib. Why did the FDA make this phenomenally unpopular decision to initially approve abemaciclib based on Ki67 at diagnosis? It's because they were being conservative. Our discussion today reflects that. We want to be conservative. We don't want to give patients 2 years of a drug that's expensive and has side effects, albeit short-term, without benefit. So what the FDA said is we're only going to approve this with 3 years of follow-up in the population with the highest risk. But then, of course, when they saw increasing benefit over time that was independent of Ki67, they had to drop the Ki67 as a criteria because it no longer was relevant. And I will note that none of the guideline groups internationally agreed or aligned with the FDA decision early.
So Dr. Rugo, again, I'll ask that question. You have answered it very beautifully, but is there, because as you rightly said, a prognostic criteria was not predictive of abemaciclib response. But is there some mechanism of action where high Ki67 has some biological parameters which specifically is downgraded by CDK4/6 inhibition? In vitro studies, any in vivo studies?
Well, you can't really do this in an in vitro setting. And no, I mean, the only adjuvant data we have is here. The rationale for this idea was that we see a drop in Ki67 in the neoadjuvant studies with CDK4/6 inhibitors across the board. So the idea was that if you drop the Ki67, could you somehow change outcome differentially? And I think very importantly, the study showed that it's a prognostic but not a predictive factor. So no, there is no apparent predictive benefit of Ki67 in terms of understanding CDK4/6 inhibitor benefit. You're impacting the cell cycle. If the cell is cycling more, maybe it would work better. But it turns out it worked pretty similarly, regardless of whether you had a faster or slow cell cycle.
Right. So Sudeep and I, when we were arguing, and I think you have said that, Sudeep also was saying that probably the patient characteristics are anyway so high risk. If you already have lymph nodes positive, say 4 or more lymph nodes positive, the impact of Ki67 anyway has been established clinically that it is a high risk. So it probably no longer may be valid. We'll go to our second last question, Dr. Rugo. The side effect profile you have mentioned 2 or 3 times earlier also. I said grade 3, 46.2% in abema group versus 15.7% in the control group. Diarrhea was 7.8% grade 3 versus 0.2%. Fatigue, I heard in one of your videos of Bay Area oncologists 3 months back that all the 4 oncologists who were discussing were really worried about the fatigue. All these patients for 2 years non-stop, and fatigue, if grade 1, 2, 3, if you take, is 41% versus 18%. Important question is tamoxifen and abemaciclib, venous thromboembolism with pulmonary embolism exceeds 4.5%. If you take both the together, it is slightly lower if you have AI instead of tamoxifen. I would again ask that question, and I know the answer. Still, I would like to reiterate that in spite of all these side effects, you still think that 6.4% makes relevance. And would you use tamoxifen with abemaciclib, or would rather you give GnRH analog and switch to AI as fast as possible?
Well, so answering the second question first, I'm a big believer in ovarian function suppression in patients who are premenopausal with high risk early stage breast cancer. I think we've seen a significant benefit. And, what's interesting here is that you could make the decision, for example, to take more of an approach like the Austrian breast and colorectal group is that you could look at patients and say, okay, you have high risk, but I don't want to suppress your ovaries for 5 or 10 years. I'm going to suppress your ovaries for 3 years. That fits in really well with giving a CDK4/6 inhibitor for 2 years. I do not give abemaciclib with tamoxifen because of that risk that I think is unacceptably high for those patients. And I don't really have a reason to, because I believe there is huge benefit from suppressing the ovaries, at least for the first few years, in women who produce a high amount of estrogen from functional ovaries. In terms of the toxicity and balancing benefit, this is really important. But if you look at patient-reported outcomes, they're quite good with abemaciclib, except for, diarrhea is an issue. Now you go back and you look at who discontinued early. That it's been fascinating being the safety chair of the I-SPY2 neoadjuvant group because of the way we categorize safety. All you need is a single event to have it be collected, right? So we found that the most discontinuations were in the first 3 months, but that most patients discontinued without dose reducing. Now, we've learned that dose reduction is easy. You can do it early. It markedly reduces the rate of diarrhea, which is quite individual for patients, and we don't have a good way of predicting. And managing the diarrhea and giving people appropriate approaches, like people will say, well, I don't want to take loperamide because it makes me constipated. Take a half a pill every other day. I mean, there are a lot of different ways that we can help patients with this toxicity and make it manageable. And I will say that although fatigue is important, diarrhea is the single most important toxicity because it limits what people can do. You can't go for a hike or things like that if you can't control diarrhea. So being able to dose reduce and adequately manage diarrhea is a critical factor. And I have found this to be very easy. We didn't have patients discontinue after we learned how to manage the diarrhea. The fatigue is something that's important. Exercise plays a role, but also dose reduction again plays a role. And outcome benefit was similar whether patients dose reduced or not in every single trial that's been done with CDK4/6 inhibitors.
I purposely didn't put the fact B slide, Dr. Rugo, because I refuse to believe the fact B lines are exactly superimposing on each other. I refuse to. That's why I didn't want to create a
The way we categorize things is not good. It's all like these single points in time.
So I didn't, and you would agree that they cannot superimpose on each other with
not in the short term, because I think that the issue is that in the short term, you have more side effects, but those side effects go away very quickly. And if you control them, patients' quality of life may be slightly reduced during the treatment, but it quickly reverts to the same as taking endocrine therapy. And endocrine therapy itself significantly impacts quality of life. So the impact of abemaciclib appears to be relatively modest.
Right. My last question, and we have just 1 minute, Dr. Rugo, I'm sorry, we'll have to give the quick answer. Going forward in US, when we do a practice in our OPD chambers, and again, this was, something Sudeep's idea, where do you see the future between ribociclib and abemaciclib? That with the NATALEE coming up in a big way, already positive signals are there. Do you think it will be divided in node negative, give ribo, node positive, give abema, or in elderly patients start with 100 BD rather than giving 150 BD, because ribo anyway 400 mg is a lower dose, which has been proving or is proving in NATALEE. Where do you see going us in next 1 to 3 years? Very quick answer, and then we move to panel, Dr. Rugo.
Well, first of all, in the 1 to 3 years, we need longer follow-up of Natalie. 20% of patients finishing 3 years isn't long enough. We need to understand whether patients all need 3 years. They're planning a study called the WIDER trial, while everybody will get ribociclib, and they will broaden the inclusion criteria further. And we argued against broadening it too far. I don't think we should be enrolling patients, who have T1B or T1C low-grade disease. But I think that we really do need that longer follow-up. When we, assuming that the longer follow-up will show similar data, I think that we're going to be differentiating use of drug based on the patient themselves and their tumor characteristics. Do they already have cytopenias? Remember, with ribociclib, you get significant cytopenias even at 400 milligrams, although less. And what is the degree of other side effects associated with each drug? And do we really think that 3 years is needed versus 2 years? So there are many remaining questions that we'll have to think about. I will say that diarrhea is a tough toxicity for patients. And so avoiding diarrhea may be preferable for at least a subset of patients.
You're absolutely right. But unfortunately, diarrhea patient lives with, while ribociclib-induced neutropenia is just the numbers we oncologists play with. So that's a slight difference between the two. With that, thank you so much, Dr. Rugo, but you have to stay on. You are one of the panelists also. I had bucket full of questions, but unfortunately, the time is never sufficient. Thank you so much. Over to Parikh, sir.
Thank you very much, Amish and Hope. This has been a very interesting and insightful discussion.
Can everybody hear him?
Yes, sir, you'll have to put the mic.
Can you hear me now?
Figure out how to make it louder.
Okay, so sorry.
Oh, no,
My apologies. Thank you very much, Hope and Amish, for really bringing out the finer points. And I think we are very clear now on why the US FDA took a particular decision and what is the likelihood of overall survival benefit being seen in the immediate future. Now we have the opportunity to discuss this further. Our moderator is Dr. T.P. Sahoo, who's a senior vocal and highly academic medical oncologist from Bhopal. And besides Professor Hope Rugo, the panelist also includes Dr. Senthil Rajappa, King of Hyderabad, Amol Akade, the most prolific Twitter medical oncologist from India, Dr. Atul Batra, whom we have felicitated just before the session because his 2023 article is so very important. Dr. Sadashivdu Gundeti also from Hyderabad. Dr. Shahida Alam joins us from Bangladesh. Dr. Ajit Menur joins us from Oman, and Dr. Ajay Bafna, who's one of the senior most medical oncologists from Jaipur. Over to you, Dr. Sahoo.
Thank you, sir. I'd like to share the screen. Just a minute. Yeah. So I think I'm audible and my screen is visible to all.
Yes.
Am I audible?
Yeah, go ahead.
Yeah. Thank you, sir, and thank you, Amish, for this opportunity. And this is a huge panel, and I think let's bring some things into perspective and let's put also the things. And I know that we have persons who would be speaking in favor of what the data is, and we heard professors speak right now, and we definitely know there are persons who would have still some skepticism about the data. Let's have a balance of the whole thing. Okay, so at present, all of us know that there are 4 studies, at least we know 2 from the PALBO, 1 we know from the ABEMA, and 1 just recently presented Natalie. And we'll just also going to speak in the last maybe 2 to 3 minutes or 5 minutes about the age, the data which are presented a few months back for the MonarchE for the elderly. Okay, this is the data that all of us know about. I'm not going to spend time on this. So we'll come down to where Amish started with the interview, and I will take the opinion of the House regarding the primary endpoint. if you look at the primary endpoint of the IDFS, there has been a big hue and cry. So now let me come to Amol first, and then I'll ask Dr. Sendil to come in. So do you think, Dr. Amol, is IDFS appropriate endpoint, or do you think that OS still is the gold standard in the breast adjuvant studies?
As per, am I audible?
Yeah, sure.
Yeah, I still feel that we need to have an overall survival benefit in the adjuvant setting, especially when the same drug can be given in a metastatic setting also, and it has been already shown in SONIA trial in the metastatic setting. So I don't think so. IDFS should be the ideal primary endpoint. It should have been the OS.
Okay, so OS for you is the primary endpoint, even what we have heard and what the trials of adjuvant breast cancer for last 10 to 15 years have been doing so. And you feel, although this MonarchE also had a secondary endpoint of OS, but you still believe. I'll come down to you with a follow-up question. Let me hear Dr. Sendil first. Dr. Sendil.
Sahoo, thank you for that question. And again, thank you for asking me to be here today. I think OS is the gold standard without any doubt. But the question is IDFS an acceptable primary endpoint or not? Is it clinically relevant? For me, it's both clinically relevant and acceptable. I think that's a much more important question. There are many things that we want to show with many of our interventions in a short period of time. But for various reasons that Professor Rugo has already alluded to, that's not possible. So when that might be difficult to achieve, impossible to achieve, waiting for a long period of time and so on and so forth, I think in the interim, IDFS is certainly an acceptable endpoint for me.
Okay, coming to Dr. Amol, have you accepted aromatase inhibitors in adjuvant setting?
Yes. And I know what is the next question.
I know that. All of us know that. So my question is much little more deeper. So at around 8 to 10 years, you have around a 2.5 to 4% IDFS benefit with aromatase inhibitors. Let's say 198, or let's say the ATTACK trial. And now you are looking at a drug which is showing around a 6% benefit at around 4 years of time. So how do you compare these two? You first, and then if Dr. Sendil wants to add something to that or criticize it, that can be done, and then we move on to the other points.
I don't think so. The comparison of the aromatase inhibitors with abemaciclib is appropriate. You are looking at one side, one very costly drug, one very toxic drug, and the other side you are looking at a drug which is lesser toxic, lesser costly. That's the first thing. Second thing, yes, aromatase inhibitors has an OS benefit only after a longer follow-up. But are we in a hope that with this single trial, I don't think so there will be any other trial ever of adjuvant abemaciclib. With this single trial, if you don't get an OS, say after 6 years or 7 years also, are we going to say that let us not use abemaciclib in adjuvant setting, or let us withdraw the approval? That will be very difficult. So I think in the beginning only we should be very clear that we need to wait for an OS benefit as far as this particular drug, which is costlier and which is more toxic.
Dr. Sendil, your quick points, and then
I think the fact cost is extremely important. Toxicity is extremely important. But the question that we have to ask ourselves is, we are making a decision for the person who's sitting across the table.
Yes.
For that person, what means may be different from what it might be for another patient. So I think this issue has to be discussed threadbare with that patient who's sitting across. Tell them what is the benefit based on the information that is available today. I don't think we should start talking about what will happen 5 years from now, 6 years from now, because none of us know what is likely to happen. We're just speculating based on the available information. So if for that patient, with the results that are available, with the cost at which the drug is now being marketed, and with manageable toxicity, is it worthwhile or not? I think that's the important question that we should be asking, rather than splitting hairs over, this 1%, 2%, because that can go on endlessly. And so if cost was not there, if abemaciclib was 5 rupees per day, I don't think we would have been having this webinar at all today, right? So I think we need to put that into perspective. So unfortunately, we have to extrapolate what happens to 5,000 patients in a study to one patient sitting across the table, right? So we don't know that. So I think that's something we need to keep at the back of our minds when we are discussing.
Yeah. Dr. Ajay Bapna, to you, for taking this forward, because this is one of the most important things, and that is the most important criticism of those who do not agree to this. let's say we have heard that in a hormone receptor positive, there are two types of relapses which we see. One is within the end of second year, and that's where the thing of putting 2 years of abema for the MonarchE came into. And we know that in this high risk subset of patients, we have around 25 to 30% relapse at the end of 5 years. We know that, and one is going to come in the late thing, that is after 10 to 15 years, we have a late relapse in the hormone positive disease. And do you think, hello, someone has two things on, there's echo. Okay, do you think that with this points that, and with the benefit that is there and the graph separating with each passing year, that's something that really interests me, that with each passing year, there's a graph separating. So do you think that we should still be waiting for the OS, which might take a decade or 1.5 decade? And would we not be then losing out a lot of patients to metastatic disease? Because the relapse in the MonarchE, it has been clearly noted that 2/3 of this relapse or more, whenever they do relapse, has been distance relapse. And once you have a distance relapse, it's a different story altogether. Dr. Ajay.
Yeah, so actually, we have been projecting hormone receptor metastatic breast cancer is something which has in this current time no cure. So there are enough chances to use the best of these drugs which we have been using in adjuvant setting very well when the patient relapses. And we have sufficient data on the overall survival and the quality of life when the patient, when we give these drugs which we have been using in the adjuvant setting, in very well can be used in the metastatic setting.
Sorry to interrupt you, but don't you think a patient with a metastatic disease, the way the patient is going to be taking a drug for life is a lot more different, and the patient will have a poor quality of life and much more costlier drugs will be given rather than not to have the relapse at all?
No, I think we should reserve these drugs.
Okay, so you are of a clear point that you will just add whenever there is OS benefit. You don't feel that the patient sitting there deserves to know the advantage that he has a lesser chance of getting back the disease, and there is a benefit which is actually growing over the every passing year. So that's the point of view. We respect that. Dr. Ajit, quickly, and then I'll come down to the next question.
So I think in any oncology trial, overall survival is the ideal endpoint. But having said that, it's a given, you have to cure the patient and let him live as long as possible. So that is the best endpoint for any oncology trial. But I think I agree with Dr. Hope that IDFS is in this particular subset is an excellent endpoint. Keeping the patient free of relapse, I think, and off treatment, I think is an acceptable endpoint and appropriate endpoint. So I agree with IDFS being a appropriate endpoint.
So OS is the least ambiguous. All of us know that. There's no controversy in that, and is the clinically relevant, that all of us agree. Early breast cancer, the points which I wanted to put forward, which Dr. Rugo has put forward, is that relatively long survival time is expected in this subset of patients. Heterogeneous and unpredictable natural history. You have some patients who have really a primary hormone refractory disease. They relapse very fast, and I think MonarchE has looked into this subset of patients very nicely. And definitely, if you look at for OS only, you will slow down the drug development process. And if in 10 to 15 years, you would have a lot more patients on absolute terms who would have benefited, would not get this benefit. And why previously DFS criteria was there, and that was acceptable because it was so heterogeneous. That's why we have the STEEP criteria, and all of us know what the criteria is all about. We have a STEEP 1 and STEEP 2. There's slight difference only in that the non-breast cancer second primaries have been not now in the STEEP 2, but this trial which we are looking at has taken the STEEP 1 because it was probably conceived before this publication came into. Okay, so now we move on, and I would like to take one point from Dr. Tannock's paper as a criticism, and I will first bring Dr. Atul, then Dr. Sadasivudu, and then Amol. I know what probably he will come to, but I want to him. That's why I want him to come last. Okay, Dr. Atul, there is a beautiful reference which Dr. Tannock's commentary or essay, what he has written on the MonarchE has put forward. And that points towards an article which telling that there is no correlation, or there is not a good evidence that a 2 years disease-free survival and a 5 years OS is there. Actually, the correlation does not exist for adjuvant breast cancer trials. And this is the reference which has been quoted. What is your take on that? That the 2 to 4 years, the IDFS is not a good surrogate marker for OS. We heard Dr. Hope speak that she thinks, and we know that she can only assume.
I think early, if we talk about specifically.
Hello. Yeah, please, Atul, go on.
For disease-free survival, and there won't be any correlation. But if you look at around 5 year or 6 year,
your voice is breaking. We are
recording the events.
Can you please? We are not able to hear you. You are not audible. I'll come down to you till you set these things. Atul, I'm not able to hear you. Dr. Sadasiv. Dr. Sadasiv.
Yes, sir. I think this
what
we have discussed till now is yes, sir. I think the 2 years disease-free survival, I think it is not a good endpoint, whatever we think. But here is again we have the 4 years disease-free survival. It's very significant. Actually, it's again the curves also separating. So that is like the curve separating means I think that definitely we are expecting some same separation in the future also. But ideally, any adjuvant setup, especially breast cancer, 2 years may not be an ideal thing. So all of us we have to agree, and including the paper also. But 4 years, I think still you can think of something 6% benefit. We have to take into something definitely significant. So in my opinion, I think this is a good study. There is no doubt. But it's separating this one thing, and yeah, I am considering is a good
Dr.
paper,
Amol,
sir, and I'm
yeah, Dr. Amol, if I went through this paper, and actually it points out 2 things. The trials that were included in this where they did not use the IPD, which we know the individual patient data is the most important way how you look at a meta-analysis. The authors tell it as a criticism. The heterogeneous trials were included here, and they actually ended up with telling that it is noteworthy the 126 studies in this analysis, which has been quoted by Dr. Tannock, did not state the definition of DFS, and there was significant heterogeneity which existed. And this was around the time when this STEEP one was going to come in. And they tell this trial ends up, this paper ends up with telling that we would like to get a heterogeneous, the homogeneous endpoint. So now, what do you think that should we be looking at? Because the paper that has been quoted also defines and tells us that we should adopt more consistent measurements and endpoints. And if you look at it, the reference 21 is actually the STEEP data. So is now MonarchE wrong in putting the IDFS as the primary endpoint?
What I will suggest is that we have to take into consideration what kind of drugs we are utilizing, whether it's a cytotoxic drug or a cytostatic drug. CDK4/6 inhibitors are predominantly cell cycle arrest drugs. They're not cytotoxic drugs. So probably in cytotoxic drugs, you may think that a 4-year IDFS may eventually correlate with an OS. But in a cytostatic drug or a cell cycle arrest drugs, is it going to happen? I have my doubts, and I will be happy if it correlates with OS, but maybe time will answer us.
Okay. So now moving forward, now looking at the inclusion criteria. Dr. Sahida, what constitutes a high risk for your practice for HR positive HER2 negative subset? Is it the Natalie subgroup of patients, or is it the abemaciclib inclusion criteria?
Yeah. So for my clinical practice, am I audible?
Yeah, you are.
Yeah. So in my clinical practice, obviously the patient group in MonarchE trial, that is 4 or more lymph node positive or 1 to 3 lymph node positive with more than 5 centimeter tumor or BFT. These are the patient I consider high risk, because for this group of patient, the 5 years disease recurrence of disease recurrence is about 30%, which is quite high.
Okay. Can I bring in Dr. Professor Hope Rugo here? Madam, important point for you. Now we have the Natalie data out. Your first impression on the data, did it really include the so-called high-risk patients? There's echo. Someone has to put mute the mic.
Natalie's an interesting trial because it included a node-negative population of patients.
Yes.
So there was a lower risk patient, and their initial press release stated that, this was the first trial that showed a benefit in node negative patients. But if you actually look at the criteria and the demographics, it's quite a lot more patients than in the actual forest plot. It has to do with the fact that, according to their explanation, that, and we haven't seen all of the detailed data yet, that they used node status assessed by the clinician and for the demographics, and node status assessed by pathology for the forest plot. But I don't still understand how it could have been a third of the patients who really had node negative disease. And then if you look at those patients, their confidence intervals overlap completely. So we remain in a situation where we do not know that there's benefit in that subgroup of patients. And it makes sense. It's way too early to see that kind of benefit where only 20% of patients have finished 3 years of therapy. So we need longer follow-up. I do not think that Natalie has established the benefit in node negative disease.
Can I ask you two questions here, two follow-up questions? If you look at the EBCT, GCG data for early breast cancer trialist data, and they look at it that even a T1 with a grade 3, the relapse rates at around 10 years is around 15%. So that's not a small number. So the grade does play a role. So is it fair that they did take up the data as it should be, that at 10 years, a 15% cumulative relapse, even for a T1 patient or T2 patient with a grade 2, 3 is not good enough, and we should be improving their data set? Point number one. Point number two, do you think because they've taken a much more lesser high risk patient group, the follow-up of Natalie will be much longer than what we see in MonarchE? It could take 15 years for the data really to mature off, because the 60 to 70% of patients are actually not having those high risk features, which 4 nodes are positive, which the MonarchE has. So 2 questions to you, ma'am.
Well, so the second question first, I don't think it's going to take 15 years. I don't think, taking a therapy for 3 years, it just would be impossible to follow those patients to wait to see a benefit. We've already seen an IDFS and DRFS benefit in the population as a whole. What will happen with the hormone receptor, with the node negative population, I suspect it will take much longer to really understand whether or not there's a benefit in that subset of patients who also had, I'll point out, high risk features, high grade histology and larger stage 1 disease. And we all have the heartbreak of seeing these patients in our clinics with metastatic disease at 8 and 10 years after diagnosis. So I do think we're going to need to follow these patients for a longer time, but it's also going to take that data in order to convince us that we should be giving it to all patients. And when we had a discussion about the wider trial, which I think will be very interesting, quite a number of us argued against just a broad inclusion of everybody with early stage breast cancer. We really needed to select out a group of patients where we could understand some risk in the node negative population. We know those patients exist. So that's the second question. The first part, which is related to your first question, was
the EBCT, the early trialist group data.
Oh, yeah.
Even the T1, T2, yeah.
Right. Really interesting data, because to us, I think we remember sitting in that room and seeing this like huge recurrence risk, out to 15, 20 years and thinking, well, wait, that's not what we're seeing in clinical practice now. And in fact, they did an analysis where there's only a median of 10 years of follow-ups. It's a much more recent cohort, and that has a much lower risk of recurrence at 10 years compared to that long-term data set. And it really has to do with the universal use of adjuvant endocrine therapy and the more appropriate use, I think, of chemotherapy, as well as separating out patients with truly HER2 positive disease for life-saving HER2 targeted therapy. So I think that, the longer term follow-up is going to show that there are still late recurrences. We see this in clinical practice, but they're not the huge number that was seen in that original analysis of patients who were treated not with current day standards.
Sahoo, can I ask one question?
Yeah.
Sahoo?
Our imaging has changed. Everything has changed over that time.
So can I interject, Dr. Sahoo?
Yeah, sure.
Yeah, so my question is to Dr. Rugo, that in cohort 2, there was deaths were twice as in comparison to the cohort 1.
Yes.
So it is a group PT3N1 hormone receptor positive. So wouldn't it be prudent to subject them to gene expression, analysis, and the low risk gene expression patients could be subjected to only endocrine therapy rather than putting them on CDK4/6 inhibitor and segregating them from the high recurrence score on gene expression assay?
Before
No,
Dr.
it's interesting.
Rugo comes in,
Yeah.
can I put the things in perspective for her? That the doubling is not, people should not feel it's a 5 versus 10 death. That's point number one. That should be put forward. The absolute numbers were 5 versus 10. The doubling words looks a lot more huge than actual numbers are. So please, Dr. Hope, please carry on with the answer.
So the I think that let's just go back to the specific question that you had about the patients who have using recurrence scores.
Yes.
I think that if you think about the recurrence score, unlike, I mean, it's a little bit different from the 70 gene score, but the recurrence score itself is driven by ERPR and Ki67 largely, although there are, of course, other genes. So a low score is going to be a patient with a low Ki67 who has a later recurrence risk and a better prognosis, but a similar benefit from the use of abemaciclib. So I don't know that recurrence score, it's interesting also that recurrence score didn't predict the benefit from longer duration of endocrine therapy. You know, patients' recurrence occurred regardless. And, you know, it's, you know, it was interesting also when you look at the analysis of one of the longer term extended adjuvant endocrine therapies and look at MammaPrint, it's patients who have the low score who seem to benefit from longer duration endocrine therapy versus patients with a high score who have this front loaded recurrence risk, and then their recurrence risk falls off after 5 years. So, you know, this is a complicated area. I don't think we're ready to use a recurrence score type test to understand the benefit of CDK4/6 inhibitors, because a patient who has, for example, 3 positive nodes and a low Ki67 still has a much higher risk of recurrence than a patient who has node negative disease. It's just they may have more endocrine sensitive and less chemotherapy sensitive disease. So I don't think that helps us yet.
Yeah, I think Natalie has that subset of patients of the recurrence score, and let's see what the data is. I think that will give us a fair idea. So now, Dr. Atul, any other issues with the inclusion criteria or anything what you feel before we move forward?
Dr. Sahoo, can I ask?
Is Atul there? Because I could not hear him, then you can come. Yeah, Dr. Atul, your voice is breaking somehow. Is it that I am not able to listen to him, or?
No, his voice is breaking. His voice is breaking.
Atul, you need to come into an area where we can hear you.
So Tarini, you instead of Atul, can I ask give that answer?
Yeah, please.
So there was a protocol amendment to exclude inflammatory breast cancer, Dr. Rugo. And there's a specific sentence written that the amendment was done to exclude inflammatory breast cancer. Any specific reason? It anyway, majority of these inflammatories are high-grade TNBCs.
High-grade TNBCs?
Sorry, high-grade tumors, inflammatory breast cancer. Why were they specifically excluded by making an amendment in the protocol?
Right. I mean, it's a good question. I think the issue was that inflammatory breast cancer is very hard to stage. And, you know, we all know from looking at lobular cancer that you can't even see the cancer by imaging when it's metastatic. So the reason for excluding inflammatory breast cancer is it's not immediately surgically treatable in a curative fashion. True inflammatory breast cancer, because you cut through tumor and skin, and the diffuse nature of the disease makes it very hard to appropriately stage and treat. So it was just really with a magnitude of caution to exclude patients where it might be difficult to see benefit because many of those patients already have cryptic metastatic disease. That was the only rationale.
Okay. I have 2-3 hands up. All the panelists have the hands up actually. So quickly, and we have only 20 minutes left in the thing. Dr. Amol, you wanted to say something first.
Yeah, I wanted to ask Professor Rugo about the inclusion criteria. They allowed patients who had underwent surgery and adjuvant treatment up to 16 months after the original surgery to get enrolled into the trial, and the staging scans were done only at the baseline. So why this was allowed to include patients so late after the surgery? 16 months is almost 1 year and 4 months. So is it possible that some patient with microscopic disease has slipped into the adjuvant trial? and the scans were done only at the baseline as per the presentation in San Antonio by Professor Johnson. So what is your opinion about this?
Well, so it's an interesting question. I mean, the reason why they gave 16 months was to allow patients to complete adjuvant and chemotherapy and endocrine therapy. But for patients with high risk disease, we always give neoadjuvant therapy. So we didn't have anybody who was that far out because there was a limit on the amount of adjuvant endocrine therapy you could receive. It was only 3 months. So, if you treat most patients, by the time you've given them 3 months of endocrine therapy, they're not at 18 months after surgery. Or 16 months or even 12 months. So I think that the number of patients who were far out was small, but the idea here was to not penalize patients who, for example, had wound healing issues, were given long courses of chemotherapy, had a big delay between chemo and radiation. You would be penalizing those patients. We don't traditionally restage at the end of adjuvant therapy. We restage occasionally after surgery if we've given neoadjuvant therapy, but it's not a standard. So I don't think you want to be adding in additional evaluations that don't reflect the standard of care. We haven't found that staging at those time points makes a difference. I think that it's different if you're looking, for example, at a study with triple negative breast cancer, because in that situation, you see very early recurrences. The recurrences occur. It's hard to find patients who recur after 24 months or 36 months. So then in that case, staging, I think restaging is important for trials. But in this case, you wanted it to mimic our clinical practice as much as possible.
And one more thing to add to this, if you look at the protocol as such, they allowed people to use the baseline, but if someone is symptomatic or had deranged LFTs or had painful lesions, they could restage it before they included the patient. So to be fair, they gave the opportunity to be restaged. It was not that they had to use it, but if someone was asymptomatic, the enzymes were normal, they allowed the baseline within 4 months to be used. I'm right, Dr. Hugo, on that?
Yes. Yeah. You could restage anytime. And we have a very low threshold for imaging in high-risk patients who report symptoms, of course.
Okay. So if there is any question on the inclusion, we can take it. Otherwise, we need to move forward.
Yes, yes, I'm Dr. Shahida. So I think I'm the only radiation oncologist here. So the trial design, the radiation therapy was allowed it, but not required. But we know that in MonarchE trial that included the patient either in 2 or EVA or in 1 to 3 lymph node or more than 5 centimeter tumor. So for this group of patients, the standard of care is adjuvant radiotherapy to reduce the local recurrence. So, and what I have seen in the criteria that 4% of patients in each group didn't receive any radiotherapy. But in the forest plot, there is nothing about radiotherapy, especially in breast recurrence or locoregional recurrence, that is 2.6% and 3% in each arm. How many of these patients didn't get radiotherapy as a standard of care?
95% of the patient of the study group, very well written in the article, have received radiotherapy.
4% didn't get radiotherapy.
That's okay.
So out of these 4 patients, so there's nothing in the forest plot regarding the patient who didn't get radiotherapy and how many of them locally recurred or locoregionally recurred.
Okay. Please, can Doctor, hope if you have the answer, put it in the chat. I want to move forward on this. This is the.
You want to ask something? Am I putting in the chat?
So she has asked that 4% or did not receive radiotherapy in this high risk group of patients. So and in these why they did not do, and why is there no data on the local recurrence data for this patient who did not receive radiotherapy? So I would like to move forward. If you have the answer, please put it in the chat. Dr. Ajit, anything on the inclusion? Very specific.
Yeah, this the starting point of the selection criteria is number of lymph nodes, more than 4 or 1 to 3. Nowadays, we rarely take 4 lymph nodes. It's mostly sentinel lymph node biopsy, maximum 1 to 2. Do you think a lot of patients would have benefited from abemaciclib would have been excluded because of this criteria?
We are talking neoadjuvant therapy? Prior neoadjuvant therapy?
No.
Patients who receive prior neoadjuvant therapy?
No, all patients who nowadays, when you do surgery, whether neoadjuvant or not, you do a sentinel lymph node biopsy, right? And you remove maximum 1 or 2 lymph nodes.
No, but if the node is positive for sentinel, you complete the axillary dissection. I don't think there's a controversy in that.
No, Sahoo. No. I think Dr. Ajit So I think, Professor Rugo, I think the question is to you. Sorry.
No,
So
please.
this has been discussed in the St. Gallen's consensus this year, and if you read the consensus, you get the answer to that question. Dr. Ajit, the point is that they have looked at patients who completed the dissection versus patients who were just sampled and then sent off for radiation. If you have one lymph node, the probability that you will fit into the MonarchE criteria if you completed the dissection is about 14%. So that's not a huge number. So the consensus of the panel was that it's fine to stick to the way we are managing these low-risk patients now, that you just sample and then you don't have to go and complete the lymph node dissection. Radiation therapy can be a substitute to completion of dissection. So Sahoo, you don't have to complete the dissection if you've got low-risk.
No. So in the preclinical thing, you have you have done a sentinel. So if there's positive, you do not complete, and radiotherapy takes care of it. That's
you
what
don't have to complete it if you fit into the criteria of the ACASOG-Z, all those trials. So yeah, I'm not talking about a T4B and clinically N0 lymph node. I'm not talking about that group.
But was this followed in the MonarchE?
No, it was not followed in the MonarchE, but this point was discussed in St. Gallen, I'd say. So the St. Gallen consensus.
So MonarchE doesn't matter on this point.
Yes, at least from a trial standpoint, it went through conventional practices.
Yeah.
Because it predated all these studies.
And I think that, you didn't have to take out 1 million nodes to be eligible for patients. If you had got neoadjuvant therapy and your nodes were negative, you just had to have a reasonable node sampling. There was no criteria for a specific number of nodes, unlike some of the other trials that we've been doing with neoadjuvant therapy, where they've required that you have a node dissection, which has impacted our accrual since we don't routinely do full node dissections in patients who had positive nodes that became negative at the time of surgery. So I think that is an important point. We will see the data from the NSABP trial at San Antonio, I think, that will discuss whether or not patients who clear their axillary node involvement at surgery really need a node dissection. And I apologize that I'm going to drop off in 5 minutes to go to clinic.
Okay. So point is, in the MonarchE, the protocol mandated if the patient had receiving neoadjuvant therapy, they had to cytologically prove from one node that it was positive, and the 1 to 3 criteria used to be followed. So in MonarchE, it's very clearly mandated that you had to cytologically prove that one node was to be positive if you are planning for neoadjuvant, and then the 1 to 3 criteria thing followed, like more than 5 centimeters or the grade. So that is something I very clearly written. So neoadjuvant the criteria would have been 1 to 3 with one of the high risk features.
So you follow the conventional way of managing. That's
yeah, please.
Tarini, since Dr. Rugo just mentioned that she has to leave in 5 minutes, can I request Dr. Sudeep Gupta if he has some comments or some questions for Dr. Rugo, which will help us, because after 5 minutes, we will not have her in the panel. Sudeep, can I
Dr.
request?
Rugo, the panel completes in 10 minutes. So only 5 more minutes from you.
So actually, I have no questions. I will make my comments in the end. I just want to say that I completely agree with what the comments that she made, and I will just elaborate on them. And I completely agree with her. I don't often agree. There are more often than not I disagree, but on this occasion I completely agree with whatever she said, and I will elaborate on that during my comments.
Okay, thank you.
So one more important point, Dr. Senthil first. Yeah, if you look at the curves, they're separating, and if you look at the numbers at risk at that point of 42 months now and 48 months, this especially at 36 and 42 months, it looks like that 25-30% of patients are being seen at this point of time. So does it look that the data is maturing nicely and the curves are separating? It does give you confidence that this curve, when the ESMO data is presented this month end, will be much better?
I don't want to speculate. I'm just hoping so that it will be better, because we've all been practicing this, and it'll be a big disappointment if it started coming together. But I doubt that it will come together. From whatever we've seen in the last 3-4 years, it's only likely to widen a little bit more.
Okay. The point of which I wanted to make is, if you look at the patients at risk, that is only increasing, and even after the increasing number in the base, you do find the curves are doing better. So toxicity was a big concern by most of us and has been spoken about. I know that all of us are concerned. Are they manageable? Dr. Sadasiv? You have found any problems as such, even with the diarrhea?
Yes, sir. These
part
are
of it?
manageable, but only thing is, yeah. Yeah, only major issue is the diarrhea. I think we have to be very careful about that one, because some people, they'll think that it's infective, they'll take something. So I think it's manageable, but better to reduce the dose if the patient is having the serious problem. So I concerned about not
So I wanted to
unless
point one thing here.
unlike any other abemaciclib, yeah, I am not.
Okay, I wanted to bring Amish in, and others can come in. We all speak of grade 3 complications, that is 43% versus, and that is what you spoke, Dr. Amish, always. I heard you 3 times at least. But if you look at the description of the grade 3 and look at the diarrhea, that's 7%. Versus if you look at the neutropenia, leukopenia, and the anemia, that and the lymphopenia, that constitute a majority of it. And if grade 3 on absolute numbers is 1200, only 200 had diarrhea, which was 7.6% of all the grade 3s thing. What is your take on this?
So Tarini,
because we just speak of the grade 3 and look at what the grade 3 really describes is mainly the hematotoxicities, and which normally was not a concern. Your comments on this, Amish?
Yeah, so I think that these are significant numbers, 7.6% versus 0.1%, Tarini. That is one.
Yeah.
Fatigue grade 1, 2, 3, I put together, reduces the quality of life. And my biggest problem in this particular paper, that they came out with a quality of life fact B. If you see the graph, they are, parallel to each other. See, this is the graph. How can you believe this? Tell me that. That was my biggest issue. There's nothing else. And as Dr. Rugo mentioned, I completely concur that living without metastatic disease is something what we have to focus on. But we also need to look at these facts, na, Tarini?
Yeah, agreed. So my concern, my point was never that it is not toxic. My point was never that it is bad. But my point of putting us, when we start putting that grade 3 is 43%, we need to also look into what that 43% really constitutes. That's what my small point was. And diarrhea, if you look at it, how many patients withdrew because of diarrhea was around 5% to 6%. The drug was withdrawn in that number of patients. Anyone wants to make a comment on it? Any of the panelists?
Yeah.
On the
Can I comment? Sahoo, can I comment?
Yeah, please.
So this 2-year period, the 70% of the patient only could take it for 2 years, and 30% didn't take it for 2 years. But the benefit was, sustained in those 30% who dropped out. So is it arbitrary 2 year, or can we reduce the, the time period of abemaciclib?
The trial came with the concept that the first risk of relapses happened majorly at the end of second year. That's why the 2 years data point was there. Dr. Hope,
but the
you wanted to
benefit
make
was
something?
sustained in patients who discontinued.
Yeah, there is the carryover effect. That also you see in the Lancet paper of 2020. That's very clearly mentioned in that. So we do see the carryover effect. How long will it last? We don't know. Dr. Hope, any points on this part of the toxicity slide?
Which point of the toxicity?
The 43% of grade 3, is it just the exaggeration? Or my point of very clear would be, is it the neutropenia or the leukopenia or the lymphopenia which is mentioned?
Remember that, we don't care about leukopenia, right? And 10.8% was the grade 3 leukopenia. But, if you look at where, and that's a big difference, right? Seeing a drop in the white blood cell count occurs. I think that, there was 18% grade 3 neutropenia, although almost no grade 4 versus 0.6%. We don't cause neutropenia with endocrine therapy. And then diarrhea was really, 7.6 versus 0.1. So it's really adding up bits and pieces of different areas where there was more grade 3. And look at lymphopenia also. As far as we can tell, lymphopenia doesn't impact what's going on with the patient, and mild anemia also is reasonably low percentage, 1.7%. So it's adding up all these bits and pieces. It's not like you're seeing, for example, when you look at neratinib, it's all diarrhea. But you're not seeing that here. So I think that, if you think about dose reductions, remember, a grade 3 event is a one event. So you have one day where you were constipated, and then you take, Senna or whatever you're taking, Miralax, and you have 8 episodes of diarrhea. That counts as your grade 3. We know most of this is abemaciclib. We don't know the number of repeated events. In our publication, looking at the toxicity, we looked at duration of events and the number of events for patients to some degree. And generally, you can control these. So yes, we see more grade 3 events, but once we understand them, we can manage them much better and try and avoid any grade 3 events in our patients.
Okay.
No increase in
Anyone?
neutropenia. Anyway, and now I have to drop off for sure. So thanks very much.
Thank you
so much, Dr. Rugo.
Bye-bye.
Bye-bye.
Okay, so anyone in the panel wants to add something to what has been spoken? Anyone?
Therefore, I think the toxicity, we have to learn to manage toxicity, right? With any drug that we have started, our problems are maximum in the first few months. Starting from Sutent down to the latest TKI that you're talking about. So till everybody in the trial learns the toxicity, there's a higher dropout for patients. Once we know how to manage toxicity, then we know when to stop, when to cut down the dose, and so on and so forth. So I don't think we should be carried away by the numbers that we are seeing. It is important to learn the toxicity, make the patient aware that these are the things can happen, and the time points at which these can happen, and make sure that they do the right things at the times that these toxicities happen. So I think education is very important to keep your patients on the drug.
Senthil,
Yes,
sorry,
sir,
the
Amish.
way you asked 5,000 rupees ka abemaciclib hota, so we would not be having
5 rupees, 5 rupees.
5 rupees, okay.
5,000 is still expensive.
So looking at these toxicity table, Senthil, if the separation of the curve would have remained at 2% only at 2, 3, and 4 years, the question what we need to ask is it really worth, even if I know or even if I learn or educate myself to manage these side effects, are we really justified in giving so much of scattered, whatever it may be, 4.5% VTE? Why would I give if only 2% is there? That is where the question comes.
Amish, I think that this decision is not to be taken by you and me. This decision has to be taken by the patient. Please remember this.
Correct.
Right? So it is important. We all have our biases. I have my own biases about many things you know about it. But I think these biases should not come into the way of decision-making for a patient.
Dr. Senthil,
I'm sure it will, but at the end of the day...
Amish put up very nicely that the curves do not separate at all. And
curves don't separate at all, then again, we wouldn't have this webinar at all, right? If the curves hadn't separated, then you're not discussing about what are the statistical flaws in this trial at all. So I think the fact that there is some benefit, there is some toxicity, and then you're concerned about the fact that overall survival may or may not be there, and that's the reason why you're discussing it. If it was so simple, why would we be calling Professor Hope Rugo, Professor Sudeep to sit here and educate us about what's going on?
So the point which I wanted to make, and I look at the Lancet paper again, if you look at the long-term part and after the abemaciclib has been stopped, they are telling that there is added toxicity now more towards the endocrine therapy alone. So basically the point which I take is this is a manageable toxicity. You have to be careful. These are early toxicities, mainly in the first 4 to 6 months, and they do not have a prolonged carryover effect of the toxicity that goes away. And actually, on the long term, it does.
Sahoo, one quick point that I want to make, and then I will stop. I'll 30 seconds.
Yeah.
So I just want to draw your attention to the soft and the text trials. Okay, when the first readout was there, 4-year readout, I think it was the median follow-up was roughly around 4 years. The absolute benefit was 4%, and the hazard ratio was somewhere in the mid-70s. Okay, with OFS and exemestane or tamoxifen or whatever that drug is. So we cannot by any standards underestimate the toxicities of ovarian function suppression, and quality of life was clearly poorer in that study. And all of us hands down said, we're going to adopt this.
Yeah.
Okay, we didn't bother about the toxicity. We said there's a 4% benefit, 5 years of ovarian function suppression. It, of course, fortunately for us, panned out in an overall survival benefit at the end of 8 years. So I think this is not the first time we are breaking our head between OFS, between DFS and OS and so on and so forth. So toxicity is there without any doubt, but is it manageable or not? Is your patient acceptable taking it or not? I think these are the more relevant questions that we have to ask.
So this is my last second slide.
Tarini, Sudeep also needs to leave. He has a meeting.
Okay, I'll come to the
love to hear
slide.
his thoughts also.
Just I'll take 2 minutes and then I'll come to the conclusion slide and then we'll stop. So this is the thing which Dr. Tannock has written, and I just went through, and it looks a beautiful thing. And if you look at, actually, there are concerns, But if you look into, and if every one of us read the articles, I would request you to go out to the cross references. Because of lack of time, I'm not going to touch that. And you would see a lot more things. And to put to Amol one question and then come to conclusion. This is the reverse Kaplan-Meier curves which has been put by Dr. Tannock. Dr. Amol, the hazards is still 0.82 and the p-value looks significant, although not to the significance which has been prescribed in the trial. What is your take on this? Although there is a criticism how it has been analyzed, Dr. Rugo wrote a lot of it on the chat. Dr. Amol.
So in fact, if you see the curves plotted by Dr. Tannock, the IDF is also not significant. There is no significant p-value.
It is 0.82. No, it is. I put forward the IDFS. This is what the IDF is: 0.82, p-value is 0.0034, and taking that every dropout here is an event. That's how the plot has been actually put forward. Although it is not touching the 0.73, which is the prescribed p-value.
So okay. I feel that censored information, censored data should be taken into consideration, because even though Professor Rugo has said that it is balanced in both the arms, if you see the numbers, I'm not convinced that it is balanced in both the arms. And I do agree with whatever Professor Tannock has written in the Lancet. I'm
okay
in favor of
I just put forward these graphs for people to read through, that even the reverse Kaplan-Meier did show a benefit, although not to prescribed limit. So my take home: 30% of patients in this subset of early breast cancer, which has been in the MonarchE, have recurrences, and these are within the first 5 years. Most being distant. That's something that we have to remember. 75% of these were distant. The first new development that happened in this area in the last 2 decades, the OFS has been there for some time. And we also looking at positive OS data. People have the concerns. I also would love to see the OS data to be positive. Are we optimally using LHRH agonist in this trial? In the eligible 43% premenopausal, if you look at it, only 50% of those patients took it, which is 20% of the whole trial lot. In India, it's much less. And Dr. Sendil rightly put, we have accepted this LHRH agonist or the ovarian suppression data very positively. And this benefit as per abemaciclib adjuvant looks little more than that. But we need to optimally use LHRH agonist, which is much cheaper. Will this space have more contenders? The Natalie is something that we are looking at very closely. It's a positive trial for the initial thing, but as for it looks at a much more lesser group of patients who are high risk, and I think the follow-up will be much longer than what we are going to see in MonarchE to get that positive result. So with that, I stop here, and if anything, if the time permits, the panelists can come in. Otherwise, it is to I'm handing over to the organizer.
Parikh sir.
Yes, thank you very much, Sahoo, Parini. Can you hear me, guys?
Yes.
Okay, wonderful. Thank you very much, Tarini. You've been, as usual, very passionate and have equally brought out the points from the other panelists as well. Since Sudeep has to go quickly, I will hand over to him to give his expert comments, and then we can take on the discussion later. Over to you, Sudeep.
Yeah, thank you. I think Dr. Ajay Vapna has his hand raised. Does he want to say something?
No, nothing. One point which we have not discussed is use of MonarchE data in germline BRCA1, BRCA2 mutated patients.
Right. Okay. So thank you, first of all, for inviting me to this excellent session. And I think it was a brilliant discussion. Right from Amish and Dr. Hope Rugo. I think Amish, you and Hope Rugo both did an excellent job of bringing out the various nuances, and as well followed by the panel discussion, which I really think had a very in-depth discussion on the entire range of questions that can be asked about the MonarchE. Now, I will give, as I grow older, I'm becoming less enamored of statistical nuances and a little more cognizant of the practical realities of life. So my take is this, that the more I see patients, I think any recurrence, any relapse is a life-changing event. And the first horror that a patient encounters in her life is the diagnosis of cancer. And the second horror that a patient encounters in her life is a relapse of the disease. And, even though Dr. Hope Rugo correctly pointed out that distant relapses are the ones that lead to mortality, But in my experience, even local recurrences are devastating, and oftentimes they do predate distant relapses. So in my opinion, a drug that improves disease-free survival from about 79% to 85%, with 2 years of use, with 2 years of oral tablets, I think is definitely something that is worth considering in a large majority of eligible patients. And of course, cost is always a consideration. Now, the other thing that I want to say is that one can always look at the glass as being 85% full or 15% empty. And we all talked about the excellent prognosis and the good prognosis, etc. But I just wish to draw everybody's attention to the fact that even the intervention arm of MonarchE has a 4-year disease-free survival of 85%. So which means that 15% of patients are relapsing at the 4-year time point, even after you give the person 2 years of the CDK4/6 inhibitor. And I think in a disease like breast cancer, 85% 4-year disease-free survival is not quite good enough. And I think we need to improve it further. And definitely 79% disease-free survival is definitely not good enough. And I think there is room for improvement, and at least some bit of that room for improvement has been made by the CDK4/6 inhibitors. Now, I think there are a number of other questions, and at least in my mind, I have no doubt that adjuvant CDK4/6 inhibitors will become a standard of care in this situation. Now, two things. One is we started with trastuzumab for 1 year, then somebody said 6 months. There was also a trial of 2 years. So I think this 2 years of abemaciclib and 3 years of ribociclib, as usual, they have been chosen somewhat arbitrarily, although Dennis Lemon says that he wants to induce stem cells into senescence, and the other trialists say that they wish to give continuous dosing for 2 years. But I think that this needs refinement. Some patients may not need 2 or 3 years, and in some other patients, perhaps 2 or 3 years may not quite be good enough. So some patients may even require a longer duration of treatment. And we have learned with imatinib in GIST that sometimes, the relapses can keep on happening, and prolonged treatment may also be necessary. The other thing is that it was very important to see that there is a carryover effect. The survival curves are widening from each other, which is reassuring. And on the question of overall survival, sometimes even with a 5,000 patient trial, it may not be adequately powered to prove overall survival benefit in a reasonable time frame. But I just looked at the Lancet Oncology publication of MonarchE, and the death rate in the two arms is 6.1% in the control and 5.6% in the abemaciclib, which means that the direction is correct. It is only a 0.5% improvement in or reduction in the death, and these are the absolute percentages, but at least it's in the correct direction. For a long time, I was not convinced about aromatase inhibitors, especially in younger women, because although disease-free survival was in the right direction, the deaths were in the opposite direction. But here, reassuringly, the deaths are in the right direction. I also have another question, and I think it is something to think about, that are there patients in whom perhaps chemotherapy can be replaced by the CDK4/6 inhibitor? And I think maybe if the patent on these drugs holds for long enough, somebody may be tempted to do that trial as well. All in all, it was a very educative session. I must also say that I think that the theme of today's discussion was somewhat harsh to the trialists. Is MonarchE sufficiently flawed? I think by no stretch of imagination can we call this a flawed trial. It's not a perfect trial, like no trial is a perfect trial, but overall, I think all of us have to agree that the trialists did a reasonably good job. And I think flawed is perhaps not the appropriate word to use for this trial. So thank you very much, Amish. 2 pence for my thoughts, and I really enjoyed the discussion.
So Sudeep, sorry, you cannot go without me asking you questions. First of all, the flawed, the very fact we put that word, it drew your attention. I think that was the main purpose of it. Second thing is, Sudeep, do you think MonarchE will see difference in OS?
So I don't know whether it will prove a statistical difference in overall survival. I think it might not. I think it might not. But I think there will be an absolute difference in overall survival between the two arms in favor of abemaciclib. It may not reach statistical significance. See, I also have to remind everybody that in any cohort or group of individuals, eventually the survival curve will drop down to 0 for all human beings.
Correct.
So the point is that, you know, we have to kind of see that in a reasonable time frame, is there a benefit in mortality? And you know, this overall survival, I am one of the biggest votaries of overall survival as an endpoint, but I think we have to also consider a little bit of perspective and context. If we ask 10 patients that you will, assuming that there is no difference in overall survival, assuming, if you ask patients that they will live disease-free, but will live for the same time, but will live the same duration, but will live with the relapse of the disease, I bet you that 8 or 9 out of 10 patients will say that they don't want a relapse, even if they have to live the same period of time. So I do think that preventing any relapse or death, and you know, we should not forget that disease-free survival also has death due to any cause if it occurs first as a composite endpoint. I think that's a reasonable endpoint for an adjuvant trial, and I think this particular study population, the authors have to be commended that they took a sufficiently high risk population where the control arm disease-free survival at 4 years is only 79%. So, you know, given the natural history of ER positive disease, we can all imagine that with another 4 or 5 years of follow-up, the 79% will drop down to close to 70%. So that means that this is a sufficiently high risk population. And I think if you look at the hazard ratio, there's about cutting down relapse or death by 1/3 is sufficiently reasonably good as an achievement. And of course, toxicity, etc., everything is there. But let's, you know, also consider the fact that this is not really haploidentical stem cell transplantation. I mean, where you are looking at 100-day mortality. And if somebody is really troubled by the diarrhea, then you can stop the drug. Then the person was intolerant. They belong to that 15 to 20% where you have to stop the drug. It's not that, you know, we are having mortality due to abemaciclib or due to ribociclib. So that's,
as you said,
that's my overall perspective.
The way Senthil said, is we have to start educating ourselves to learn how to manage side effects and accept IDFS as an acceptable primary endpoint.
With sufficient magnitude of benefit. And
correct. That's an important point. That's an important point. Again, affinity 0.9%.
Yes.
IDFS is positive, but it's not clinically significant. Yes. So you should have a clinically significant magnitude of benefit that is acceptable for us and our patients. Very, very important.
Yes, with sufficient magnitude of benefit.
Absolutely.
Yes.
Look at Dr. Gundeti's screen was frozen with such a smile. Over to Parikh sir for...
No, the reason why it's frozen so because I keep on hammering this when we have our local meetings, and that's why he's smiling at me.
Parikh sir, before we end, just Dr. Ajay Bafna's question, and Senthil or anyone can take it. BRCA positive, 4 nodes positive, what would you do it? Just
so I think that's also been discussed, isn't it? So you first finish the BRCA issue. I mean, that means if you again you believe in the 2% survival benefit of using olaparib for a year. Let's not split hairs over whether 2% is significant or not. That's for another day. So you finish that 1 year and then start your patient on abemaciclib. I think that's fine. That's what is.
And MonarchE allowed 16 months to randomize.
So that's the reason why we are saying it's okay to do it later.
And even Natalie used much more longer period of endocrine therapy even, and then
that's right. I think it's about 12 months or something in that.
Yeah. So you finish olaparib and then start.
Yeah, I think it's fine to use both. I think it's fine to use both in sequence, not together.
Yeah, in the Olympia trial, most of the patients were triple negative actually. Only about 20%, I think, were.
Yeah, it was 18%. Again, the question of whether that is valid in patients with HR positive comes because the confidence interval is wide and you've got only 18% of patients who are HR positive. Again, let's not get into that argument today. That's for a different day.
Sequences.
Okay, over to Parikh, sir.
Right. Thank you very much, everybody. I
Sir,
think
Mike.
यार ये तो मैं भूल ही जाता हूँ. Thank you very much. I think it has been a very intense discussion. Only the panelists and Sahoo are still here to listen. The interviewee and the concluding expert have to leave for some reason. So I will also not waste too much time. I'll just remind you guys that the next OBTO will be on the second Tuesday of November, which is on 14th November. And I hope that all of you will join us in another academic piece. Thank you very much.
Thank you.
Thank
Thank
you
you,
so
everyone. Thank you.
Lovely, Amish. Lovely, Amish.
Thank you so
Lovely.
much.
Yeah, beautiful.
We can close the meeting.
Yes, please.